My name is Stacy Stewart, and I'm President and CEO of the March of Dimes, and I'm really excited about this conversation today. This is another episode of our Healthy Mom, Strong Baby series, and this is a conversation that we need to have, and for a lot of people, it is a very real part of our lives that many of us face, especially women of color and our families every single day. And it's a reality in this country in particular, around the world, that is an important conversation for us to have. So I want to say thank you in advance for all of you joining us. This conversation is about racism and how it impacts the health of moms and babies. This is a conversation that for a lot of people can be very triggering and it can be very emotionally charged. But what we hope is that we can have a really healthy conversation about this. I know that we will with our fantastic panelists. And we'll also be offering a whole range of supportive resources at the end and probably throughout in the comments on Facebook, comment section on Facebook. So please be checking that out and please look at the end of the session today for more resources if you are needing to follow up on any of the topics that we discussed today. One of the things that we focus on at the March Dimes is around maternal infant health. And one of the areas that we're very concerned about with respect to maternal and infant health is the health of all moms and babies, but especially the health of moms and babies of color, because we have such unacceptable outcomes with respect to maternal and infant health outcomes for moms of color and babies of color, especially Black, Indigenous, Hispanic moms and babies of color. We are living in a system, a healthcare system that is frankly failing many women, and many women that look like me and others that are on this panel today. There are multiple health and societal and economic factors that are all contributors to this. Unequal access to care, chronic inequities and unequal access to quality care are just some of the issues that contribute to the maternal and infant health crisis that we face. Here in the United States, pregnancy-related mortality for Black women is nearly 3 times higher than the rate for white women. And the rates for American Indian and Alaskan Native women are nearly 2 times higher than they are for white women. In addition, the increase in pregnancy-related mortality for Hispanic women from 2019 to 2020 was significant. And then when we look at the health of babies, the rates of infant mortality are also alarming. Infant mortality among Black babies and American Indian and Alaska Native babies are almost 2 times higher than they are for white babies. And premature birth rates are also extraordinarily high for women of color, especially Black women and other women of color. For Black women, preterm birth rates are 50% higher than they are for white women. So these are just some of the facts that exist. Part of our dialogue today is going to be, how did we get here? And what are the underlying causes and reasons for why we see these tremendous disparities and inequities? Why is it in this most advanced country in the world, one of the wealthiest nations in the entire world, why do we see such persistent poor outcomes for moms and babies of color? And why is it that in the United States of America, we have many women of color who frankly do not receive the same level and quality of care as other women do? So it's with this in mind that we begin our conversation today, really looking at the goals the goal of sort of uncovering some of these issues, really trying to understand and explore the causes and the potential solutions to some very deeply troubling disparities. But before we begin today, I want to show a quick video that relates to this discussion today. It concerns what we assume about others at first glance. You know, there is an idea that we often talk about called implicit bias. It is something that actually plays out and can play out in very devastating ways. In fact, leading to very poor outcomes, even death for some women of color, when that implicit bias interferes with access to quality care. Some of the perceptions that a lot of us have about others are based on very negative social stigmas. And something that might very well be one of the underlying factors in today's conversation on the maternal health of women of color are some of these first impressions and these ideas that people have about others, again, based on stigma. So this video is called Words Have Weight. It's a video from the March of Dimes' Beyond Labels initiative. And it is trying to address the issue of social stigma and trying to address the issue of the negative perceptions that people often have of others based on race and ethnicity. So let's look at a quick clip of this video.
As humans, we constantly make judgments about others and place them into categories, often without realizing it. The labels we project, whether we say them aloud or think them to ourselves, affect how we see and treat each other.
Weak. Irresponsible. Uneducated. Welfare mom. Selfish. A drain on the system. Lazy. Unhealthy.
Words have weight. The labels we place on others weigh them down. They create shame and perpetuate stigma. And this stigma makes people less likely to reach out for help when they need it. Amber, Anna Maria, Stella, Natalie, mother, neighbor, friend. We all have a role in reducing stigma. We can start by looking at ourselves, our beliefs, our judgments. Look beyond the labels. See the person underneath. Find out more about reducing stigma.
That's just one aspect of the issue we're going to be talking about today, because I firmly believe that a lot of these stigmas and beliefs that others have about others that are not like them are deeply rooted in our history in this country. They're deeply rooted in bias that has persisted over many, many, many generations. And it really gets the root of what a lot of Black women and other women of color really express, is that, especially with respect to sometimes dealing with the healthcare system and with people in general, that we're not seen as even fully human. And that really comes from a time period in the history of this country when Black people and other people of color were in fact not seen as fully human. And that's some very, very troubling history that a lot of people are very uncomfortable talking about. But we have to address it and call it out, because it actually is affecting lives today. It is affecting the lives of moms and babies of color. It's affecting our ability to have women and babies of color and families of color access the best care possible. And to the extent that that's happening, that's simply unacceptable. And at the March of Dimes, we're committed to making sure that there's not one mother and no family that has to go without the highest level of care that they deserve. And so that's part of what we want to try to uncover in this conversation. If you've got comments and questions, we certainly invite the conversation on Facebook. We certainly want to invite your questions. Questions are really important, and there's no dumb question, by the way. Sometimes when people ask questions, people feel like they're set up for the attack. And I want to make sure that people know that this ought to be a safe environment, that when there are questions that people really have, there needs to be a place where people can ask questions and really get respectful answers. And I hope that you'll find that this is a safe place for that today. So with that, I want to just invite you to engage in the conversation on Facebook, and we'll be sure to get those comments and questions, and we'll be sure to raise them on this conversation and with these amazing panelists. So with that, I want to introduce all of them that are here today. Anousheh Hossain is our first panelist. She's a writer, she's a feminist, policy analyst focused on women's health legislation. She's the author of The Pain Gap, How Sexism, Racism, and Healthcare Kill Women. It was published in 2021, and she's joining us today to talk about her findings and also what we can do about the women's health crisis in the United States. Linda Goler-Blunt has a master's of public health and epidemiology. Is the president and CEO of the Black Women's Health Initiative, I should say, a national organization holistically focused on Black women's health and wellness. Linda has been a great friend of mine and a great friend of March of Dimes, as has Black Women's Health Initiative for many, many years. As part of her work, she has delivered more than $25 million in programs for Black women to prevent chronic disease and to promote health. Next will be Dr. Divya Cantor. Dr. Cantor is a board certified OBGYN with over 2 decades of private practice in women's health. Today, she serves as the Chief Medical Officer for United Healthcare of Kentucky for Medicaid plans. Next is Dr. Terry Major Kincaid, a proud graduate of Prairie View A&M University. I must say that same school as my husband, so I had to put that little plug in. She's also a double board certified neonatologist and pediatrician, longtime volunteer, and friend of March of Dimes. She specializes in the care of premature infants. You guys got to follow her on social media. She's amazing, as are all of our panelists, I should say. She's an expert in neonatal palliative care, pregnancy and birth related health disparities, and physician-parent communication. It's always good to see Dr. Terry. We just usually call her Dr. Terry. Tamika Isaac. Tamika's been with us at the March Dimes before. It's so great to have her back. She's the co-founder of Jace's Journey, a leading voice for reproductive empowerment. A life-altering experience called her to this work. She joins us today. She's going to be able to share her story and share how it led her to become an advocate for health equity and eliminating racial disparities in pregnancy care. Tamika, we're glad to see you. And then finally, Dr. Takia Talbert is the Chief Diversity Officer for the University of Kentucky. We have a lot of Kentucky folks here today, which is kind of cool. For the University of Kentucky's healthcare system, she oversees and supports the organizational diversity, equity, and inclusion activities. An important part of Dr. Talbert's position is connecting UK healthcare's DEI efforts with those of the university and connecting those teams to the community. So I'm going to simply moderate this discussion. We have so many great points of view and expertise here that I want to make sure they are able to share all of their amazing insight today. And I've already told them when I start this conversation, feel free to just weigh in and jump in after we do some of the initial introductions. So with that, I'm going to start with Anusha. Your book is phenomenal, and we're so thrilled that you are joining us today. Would you just talk a little bit about what inspired you to write your book, The Pain Gap, How Sexism and Racism in Healthcare Kill Women? What was your personal experience of trauma giving birth? If you could just share that story with us.
Thank you so much, Stacy, and our esteemed panelists. I can't tell you what an honor it is to be in your company and March of Dimes. So thank you so much. What inspired me to write this book was discovering America's maternal health crisis. I was born and raised in Bangladesh. That's where I grew up until I was 18 years old. I know a lot of people are like, well, you sound completely American, but I was born and raised in Bangladesh. And in the 80s, we were kind of the poster child for maternal mortality. You know, we had one of the highest maternal mortality rates in the world. And it was really kind of America that came in with USAID and introduced the concept of public health, maternal health. How important it was for women to be able to access, you know, family planning and reproductive health services, how important that is for the economy and everything else. And I kind of grew up thinking that America was a feminist utopia where it was impossible for women to die in childbirth. Of course, now it's been 25 years that I've been here, and my experience giving birth in America is really what inspired my book. Initially, I wanted the whole book to be about America's maternal health crisis because after almost dying in childbirth in one of the top hospitals in America, in Washington, D.C., even while I was dying actually in childbirth, almost dying, I kept telling myself, but I'm not going to die. I'm in America. I'm in Washington. And I had no idea, even though I was a feminist policy analyst working on Capitol Hill on global health legislation, what was literally happening in our backyard. So that is really what drove me to write the book. But of course, initially, I wanted the whole book to be about America's maternal health crisis because I didn't understand how this was happening in the richest democracy in the world. As we all know, not an issue of lack of expertise, resources, what have you. But then the pandemic hit. And my agent was like, nobody wants another book on another health crisis, a different health crisis. And then when I went in to rework the proposal, I mean, in a way, the pandemic in many ways was a blessing because it really kind of exposed what was happening with women's health in America. So I just broadened it, but that basically is the impetus.
Yeah. And I want to come back to your personal story, but I also want to bring in some of the other panelists. So we'll circle back with you, Anushe. Thank you so much. I want to turn it to Linda Goler Blunt. And one of the things I love about Linda, because of her deep expertise and the work she's been doing in Black women's health over decades, she's not that old, so I shouldn't say, I shouldn't emphasize the S too much, but she has extensive experience in this, and she's super young, as you can tell. But one of the things that, Linda, I'd love for you to share is how you talk about how we got to this place, these disparities, and also with respect to Black maternal health, the issues of maternal weathering, I think are really enlightening. So give us a lot of that context that you've studied for so long and helping us understand how we got to this place of these kind of poor outcomes and inequities that we see.
Well, thank you. In my youth, I appreciate that. You know, Stacey, and I just want to add my thanks and appreciation to be a part of this conversation. You know, people keep asking about, you know, what are the signs of hope, and I'm looking for them, but it's challenging. You know, for Black women, where we are now is 400 years in the making. But if we can go back to, you know, 1940s and fast forward to 1990s, the maternal mortality rate dropped. The gap between Black and white women didn't change, but it dropped, but then it started going back up. So literally from 2000 till now, the maternal mortality rates have increased 25%. But we can go back to the very first report that looked at health disparities. Margaret Heckler, she was then Secretary of HHS, talked about the differences in outcomes for Black Americans and white Americans. Not much has changed. So we know there are reasons that explain it. Obviously, you know, systemic racism, but also at policy levels, defunding family planning services made prenatal care access more difficult. The growing rates of obesity, the change in food policies that actually happened in the early 70s, which contributed to the obesity epidemic we have now, is responsible for obesity-related conditions, diabetes, obviously gestational diabetes, the closure of maternity hospitals in low-income neighborhoods or rural areas made care more difficult, the under-resourcing of these hospitals. So when there are emergencies, perhaps like Anushe experienced, there's not even the resources to deal with those emergencies in some of these hospitals. And then increased economic inequality, which is we see in the form of, for example, racial segregation, the pay gap that exists. Something that I think is worth mentioning is if we could eliminate neighborhood racial segregation, we would actually eliminate health disparities. That's how closely they're tied. Mm. And I just want to mention, you know, we tend to think of this as an issue of poverty, but Black, well-educated, high-income earning women have worse maternal health outcomes than white women without an 8th grade education. So all of this environmental stressor weighs on us, and our bodies demonstrate it. They play it out in terms of low birth weight babies, premature birth, maternal deaths. And we know now that we've got 30 years of research that looks at this effect. You talked about weathering. Arlene Geronimus talked about what chronic exposure to racial and gendered stress does to our bodies, literally causes Black women and brown women to age faster. We know from Tanae Lewis, it affects us at the DNA level. The Black Women's Health Study, we partnered with them, and Fleeta Mass Jackson look at causal relationships between racism and gender discrimination and uterine fibroid tumors and maternal mortality and infant mortality. So these things are closely tied. You cannot actually tease them apart. So if we're going to deal with this issue, we've got to deal with the systemic contributing factors. This isn't something that Black and brown women can do. We've got to deal with policy and systems.
Yes. Yeah. It's really shocking. And this issue of weathering and how constant stress and the effects of stress actually have a biological impact on our bodies, and how that then translates into poor outcomes for ourselves as women, as moms, and then for our babies is very real. And I think that science is something that I want to make sure we bring out in this conversation as well. It's not just a social or policy conversation. We're actually talking about a medical and health related issue that is impacted by the way in which our society operates in inequitable ways for so many women. So thank you for that. We'll come back to that. Dr. Cantor, I'd like to turn it to you if I could. And just so glad you're here for this conversation. Can you just speak a little bit to the current state of infant and maternal health in this country, especially as it relates to moms and babies of color who are covered by Medicaid? And what are you seeing in that population? By the way, a lot of people don't realize that Medicaid covers over 40% of all the births in this country. When we talk about Medicaid, we're not talking about an insignificant part of the healthcare system and what it's doing or not doing well enough to protect the health of moms and babies. So Dr. Cantor, if you could speak to that, that would be great.
Thanks, Stacy. And I really appreciate you and your work at March of Dimes. I've been a big fan of your organization, and to all of the panelists, amazing. I'm so happy to be here with you. The poor maternal and infant health outcomes just remain unacceptably high. And much like Anushay said, it's incredible to me as an obstetrician that this is where we are, and that the majority of deaths that are occurring to women of color. The other set of women that this occurs to are those that have substance use and opioid disorder. And in Kentucky, we deal with that a lot. So that's if you're thinking about who are these women that are dying, they're women of color and they are women with substance use disorder. Unfortunately, that is something that, as Anushi said, that it's occurring in resource-rich countries, which is so sad, 3 to 4 times higher. You also mentioned, and I'll emphasize, the preterm birth rate remains incredibly high, and it was rising until 2020, where we saw then a slight decline. But women are giving birth preterm rates higher for African American women, 50% higher than they are with white or Hispanic women. And women who are delivering preterm births, those babies can have lifelong physical disabilities, ranging from not being able to see, hear, or walk well. They also have brain neurological dysfunctions, so there are developmental delays. These are lifelong problems that occur. And within the Medicaid aspect of it, at United Healthcare, we've made a commitment to be able to drive more equitable care. So we do this with partnering with trusted partners, healthcare providers. Recently, we provided $14 million worth of grants to community-based organizations across the country, specifically aimed at improving maternal health outcomes.
Really great. And love to come back to you too about what we see in the Medicaid population, because I think it's really incredibly important to understand. Although it's really interesting, and just to bring the point back up that Linda raised, which is that these issues of maternal mortality, morbidity impact women of color irrespective of income levels. And that is, I think, one of the things that is really shocking, that women, Black women and other women of color that are highly resourced with great education, great income, resources, all the resources they could ever need, are still dying at higher rates than white women that are not even high school educated, which I think is shocking. Dr. Terry, I want to just come to you though, we talk a lot about maternal health, but I think, obviously you can't have healthy babies unless you have healthy moms. And what you're seeing is the impact of this failure for women, how it plays out with our babies and our newborns, and especially around premature birth, but other issues as well. So as a neonatologist and pediatrician, what are you seeing are the effects of these issues of racism and discrimination and inequity, and how that's playing out with respect to the health of newborn babies?
Gosh, do we have enough time? Okay.
You have enough time. Take your time.
First, I just want to say again, thank you for inviting me. I just love that March of Dimes is giving a voice to this issue. For me, it's like self-care that I'm going to actually get to say racism out loud today. So thank everybody. So with respect to challenges that I see in the immediate period, I always say that the challenges that happen in the NICU for babies that are admitted to the NICU are challenges that are going to stay with them. The newborn period is so important for imprinting and development. And the most immediate thing I see as a result of the impact of racism is a disrupted birth experience. It's a disrupted birth experience that starts before I ever meet you. And so that could be preterm birth, which brings with it a long hospitalization, disrupted parental infant bonding, challenges with visitation for marginalized communities, judgments that form in the NICU based on how often a family may have the privilege to be at the bedside, differences in how we encourage families to breastfeed, which in fact impacts infants well after they leave the NICU, but also term infants. So term infants who may have an emergency delivery, an emergency C-section, a mom who brought up a complaint and she wasn't listened to, a mother of color, a Black woman who wasn't listened to. I can't tell you how many times I hear a story from someone who knew something was wrong and they went to their healthcare provider and they were dismissed. And so now they have a term infant who's in the ICU nursery who may have brain damage, requires CPR at birth, or even a stillbirth. And so one of the things I think is really important for our listeners to hear is that a lot of time, I'm so glad we're all talking about SES status and for how Black women is not protective. But a lot of times people say access, access, access. And I just want to say access doesn't mean anything if you're in front of someone who doesn't believe you deserve the same standard of care. If when you see me, you don't see your wife, your mother, your sister, and you think I warrant the same standard of care that you would want for your loved one, access is not going to help. Access is not going to change that. And so to change these disrupted birth experiences, I love that Linda said this problem is 400 years in the making. We got to get to our moms, our babies, our families well before they ever get to the hospital. And I love what we said about zip codes, because I may, as a pediatrician, want to know about your shop record, but really I just want to know, in 2022, I need to know your zip code, because today your zip code is more important than your DNA. And that's the definition of a disparity, that I can predict your outcome just based on where you live in the United States. And that's crazy. I mean, that's just crazy.
Yeah, that is really. Well, I want to, we have a lot of circling back to do for sure, but thank you for that. And I want to bring in Tamika, because Tamika, you've have really a painful story about the loss of your son, Jace. And we're so sorry about your story and so sorry for your experiences. There may be some that are not familiar with your journey. So would you just take a minute or so? I know a minute's not long enough, but would you take some time to share with us the journey that you've been on and the story of Jace?
Absolutely. And again, thank you, like everybody commented, thank you for having me here today. Let's talk about Jace. Jace was amazing. He was the best thing I've ever done. I got pregnant with Jace in November of 2017, and we were doing really, really well. I was like, I didn't have morning sickness. I would sing to him in the shower every morning, "You Are My Sunshine." I try to get my husband to sing, but y'all don't even want to hear that. And we were doing really well. I was told early, I was 40 when I got pregnant. So you're considered high risk at 40. And I was told I'm high risk for preeclampsia. And they put me on a low dose of aspirin. So of course, this is my OB that I had gone to for years. So like for my annuals, I've gone to this person. So I was like, this is a natural transition. So as soon as I found out I was pregnant, I was like, let me call him and, let's set this appointment. And I did. And of course they were like, well, you can't come right now. You have to wait a couple weeks. So that's what we did. And like I said, my pregnancy was amazing. Jace was great. And at about 34 weeks, I'm going to my weekly appointments at this point, and they tell me he's measuring small. And I'm like, okay, what does that mean? Like, okay, we're like, well, we want you to go to maternal fetal medicine to get an ultrasound. So I end up going to maternal fetal medicine. I get an ultrasound, and it was inconclusive. They couldn't see my umbilical cord. They said he was moving too much, but I have another appointment the next week. So we get to the next appointment, And they're like, well, he failed a non-stress test. We need for you to go back to maternal fetal medicine and get another ultrasound. I'm like, okay. So same day, just like the week before, I go back to maternal fetal medicine. I get this ultrasound and they said, oh, he's fine. So I'm like, oh, okay, well, he's fine. I go about my weekend. It was Mother's Day weekend, 2018. That Sunday night, my stomach was like hurting real bad and it woke me up. So I woke up. I thought I had food poisoning, you know, pregnancy. I mixed a whole bunch of stuff. I wasn't sure. I was like, it's gotta be food poisoning. I don't even know what I ate. So I go to the bathroom, but I couldn't poop basically. And then I threw up. I felt better. So I went back to sleep. I woke up that next morning and I was like really sore in my abdomen. And in my mind, I'm like, well, you threw up. I haven't thrown up in probably 3-4 years. I'm just sore from throwing up, but I didn't feel well. So I just kind of laid in bed. My best friend was there. My husband had called her to just in case I needed something. And she was there. And that afternoon I was like, well, I need to go to the bathroom. And I called her because I was still feeling sore, asked her to help me go to the restroom. And when I stood up, I passed out. So I'm rushed to the ER. I get there about 6 p.m. I think they do a Doppler. I'm kind of lethargic, not really here in and out, kind of very dehydrated. And about 7:50, they do an ultrasound and they say, your son died in utero. Just like I just said it to you. And me and my husband are like heartbroken. Like, what are you talking about? And well, we don't really have a lot of time to talk about that. You have HELP syndrome. Again, we're sitting there like, what is HELP syndrome? Never heard of it before in my life. And they were like, we have to induce you. And I'm like all this information coming at me at one time. I'm again hooked up to IVs, monitors, a catheter, all these things. And they're like, we have to induce you. And I asked for a C-section. I was like, I don't think I can do this. I can't be in labor and him not be alive. I can't do this. And they were like, no, we have to induce you. And they never really explained why. They said that I had to be transferred to another hospital. So I'm waiting on transport. Again, I'm there at 6 o'clock. They tell us Jace had passed away at about 7:50. 9:59, they do a CT scan. The results don't come back right away. I think they actually sent those to the other hospital. So I finally leave the hospital at 10:43 p.m. As I'm in transit, a resident, Dr. Rachel McCabe, my forever angel, realized I was bleeding internally and called back. And they were like, well, did y'all know she was bleeding internally? And they had no idea because they just did the CT scan. So I'm then rushed into emergency surgery. I'm wheeled into the OR, and the last thing I really remember is someone telling me that they were about to give me a C-section. And I remember being puzzled because I had the conversation about the C-section. And then I was out. They put me to sleep. I had a liter of blood in my stomach. I had a softball-sized blood clot on my liver, and I was dying. As Anashe said, I was dying, but I honestly had no idea I was dying. Like I had no idea any of these things were going on. I was bleeding so, like my platelets were low, which is a part of HELP syndrome. So that's hemolysis, elevated liver enzymes, low platelets. So I'm bleeding water. Like they cannot stop the bleeding. They tell my husband, we've thrown everything at her. We don't know she's gonna wake up. We don't know. We don't have anything else to do. We can't do anything else. If she wakes up, it'll be Thursday or Friday. Mind you, this is like very early Tuesday morning. I woke up on Wednesday because I'm a fighter. I'm a fighter. And my mom, Jace is in my room. Apparently he had been there the whole time. And my mom asked me to hold him if I wanted to hold him. Mind you, I have mitts on and I'm intubated. So I can't say anything and I can't see. So I wear contacts glasses, as you can see, but I couldn't see anything. Like it was a blur and I didn't have anything there to see him with. So I ended up getting my husband's glasses, We do not share the same prescription. And for less than 5 minutes, I held my son. And then a nurse comes in and they're like, we have to take him to the morgue. And they took him away. That was the last time I ever held him. That was the last time I ever saw him, because I would eventually be in the hospital for 45 days and have 7 surgeries. I was still open that morning I woke up, because they had packed me with what you call sponges. I'll call them sponges, to absorb the blood, because they weren't sure, when I was going to stop bleeding and if I was. So I was still open. They closed me up, but then I caught an infection where they embolized my liver. And it was the worst thing that has ever happened to me. I was finally released and looking at my medical records, and I realized the whole time I was pregnant, my doctors never did a urine sample. They did blood work the first day of my 3rd trimester, but even when Jace was measuring small, even when he failed a non-stress test, they didn't do anything. And a urine sample could have detected the protein that was in my urine, because my urine was black when I got to the ER. So I was dumbfounded. I was like, what? And I was trying to figure out what happened. Like, how did we get here? And then I found out about the maternal health crisis, just like honestly, I'm like, what? Like, this cannot be possible. Like, this cannot be possible. I have 2 master's degrees. I had private insurance. I went to every single one of my appointments. And I did everything they tell us to do. I did everything right. We did everything right. And we still lost our son. So we started Jason's journey because first, we don't talk about stillbirth, and people will know my son. They will know who he was and how loved he was. And I know that, like, he saved my life. So people will know him, but we're also going to have these conversations. We're going to talk about stillbirth. We're going to talk about this crisis. And we are going to have to do this earlier than a pregnancy test result.
Right.
And that's why I'm here. That's why we started a nonprofit. And yes, this conversation is going to be amazing.
Yeah. No. Boy, I am so thankful that you shared that, and thankful that you were able to share that. That is such a difficult, I know it was difficult for us to hear. It was far more difficult for you to experience and for you to share that with us. You and your family have gone through so much, and we're glad that we can honor Jace's life here and honor the lives of other moms and babies, and hopefully protect their lives as well, because we are talking about it openly and honestly and transparently. So thank you, Tamika. Dr. Talbot, I want to come to you. I mean, honestly, just reflecting on what you just heard, your work at University of Kentucky is really around diversity and inclusion, and how do we create a different culture in our healthcare institutions so that no mom, no family has to deal with these issues. That when a mother says something is wrong with me, like Dr. Terry said, that someone listens and responds and doesn't, pass judgment on someone based on who they are, right? As a full human being. How do you do that? How do you do that at University of Kentucky? And how should we do that as collectively in the system of healthcare that we're in?
Right. So first of all, just like my other fabulous esteemed members, I just want to thank you, Stacey, and I am so honored to be with such beautiful women, intellectual women who know so many things. And I believe, we can change the world. It may be one state, one baby at a time. And Tamika, to you, I mean, to have to follow you, it's humbling. It's humbling. But I will tell you, Jace was blessed, right? And his legacy lives on through you and your husband. And I just applaud you for the work that you're doing and for sharing that story, because oftentimes that gives face to this problem that we have, right? In our nation, in our world. So thank you for sharing. That was incredible. So what do we do? And just as several of you have pointed out, this has been an issue hundreds of years in the making, right? So you can't, while some of the things you may start out doing may be small, it must be expansive and look at all facets of this problem, because Dr. Terry pointed out, it's not just the fact that we want to improve access to women of color and all women from all backgrounds. We have to have people at the bedside who understand those individuals and who will listen to learn and react accordingly, right? So that we don't have Tamika's come into our place and have outcomes such as that, that physicians aren't listening to our patients and making assessments and other people on the healthcare team. So I just kind of want to approach this from the lens of a DEI plan is something that has to have the diversity, the equity, and the inclusion, all three components. It's not just one of those. It's not just saying that we want to try to hire more Black and brown people, because it's so much bigger than that. We also believe that people who are Caucasian and not of color, if you will, have cultural sensitivity when taking care of their patients, because we know we can't do patient and provider concordance with every single patient, right? So it's about all of us being accountable and being held accountable. So the DEI roadmap or strategic plan should be visionary, expansive, and aligned with the organization, because basically our success is the success of our DEI plan. And again, it has to have all facets. So not only are we looking at workforce utilization and diversity for representation so that we can have patients like Tamika and Anusha come and see people who look like them, but also see people who have been trained and on cultural humility, right? And we try to avoid the words of cultural competence, because to me it implies that there's an endpoint and that we can all somehow be competent one day, and we can't. It's evolutionary, right? And it's ongoing. So that diversity is looking at not only how we look, but how we hire, how we retain, and how we make people feel a part of that environment so that they stay. Because as much as we can work on who we are and how we look and how we behave with one another, we're really then our best selves at the bedside. When Tamika and Naneshe, and when individuals are coming to us, we're showing our best side, and we're fully equipped to deal with any patient from any background. Doesn't matter if they look like us or not, you're going to get the same quality and process and protocol of care delivered. So your plan has to make sure that there's a zero tolerance around anything less than that, right? So it's not only looking at our workforce and their training, but it's looking at the inclusion of those individuals and that sense of connection and belonging and equal opportunity to develop and grow, so that we're all equally prepared to take care of whatever may and whoever may present themselves. But it's also the equity piece in terms of the policy, the language, the care protocols that we have in place. I mean, there's so much out there about maternal health and bundles of care, right? No hospital should not be doing it, right? It's not an option to not have those things in place, and that it's by design and not default, because we cannot have, we must have our Jaces in the world. We have to have Jaces. So such a beautiful story and such a great inspiration. And I think that the other part of having this DEI plan is the fact that not only that we have to have all components, but we have to have ways to measure impact, because we can't address what we can't measure. So we can always talk about what we're doing and what we're going to do. Well, we have to do those things and stop just talking about them. But when we're doing them, we must position ourselves to be able to measure our impact. So I think that that's the other important component of a DEI plan and what hospitals have to do. And I think that you also have to have implementation milestones. I mean, again, it just can't be a conversation about how great we want to be. It's about how we're achieving those things and looking at some timeframes and some measurements to say, we did that. We're there. Now we're going to move the bar a little higher, a little further down the road. So one of the key things that I've known, and with UK Healthcare and with other places across the nation, is that people have not really put in expansions or health data infrastructures that look at disaggregation and stratification of outcomes. Again, we can talk in a very high level that we're doing well and our outcomes are pretty good. But I will tell you, we all know, because those social determinants of health and these 400 years of looking at this problem, identifying it over and over, that we're still having these conversations today. And so what we have to do is also look at how people of different races, ethnicities, limited English proficiency experience healthcare. That's both from a patient experience perspective, but also from an outcome perspective. You know, if we're having severe maternal morbidity, and if we're having increased number of C-sections and mortalities and deaths and infant deaths, what do those babies and moms look like? And a lot of people can't quantify that for the space that they occupy. And that's just something that can no longer happen.
Yeah. You know, one of the things I just want to say, and I'm already feeling that we're going to need to have part 2 of this at some point, because we will not be able to we're just even scratching the surface of this conversation right now. But, you know, most of what we know about our health and wellness is really determined by how we live. I mean, we're talking a lot about the healthcare system and what happens in hospitals. And certainly there are, like Tamika's story, Anushe's stories, failures in the healthcare system, but the failures happen before people even get to the system, right? The failures happen when people don't have adequate access to safe, decent, affordable housing, when they don't have access to good nutrition, when they don't get paid fairly in the workplace, when they're mistreated in the workplace. I mean, all of these different, what a lot of us, you know, nicely call social determinants of health, these are big factors that determine the majority of our overall health. And for women of color, we live in environments and we live in situations and with different kinds of issues happening in our lives that really affect our ability to be healthy. That's even before pregnancy. Certainly our health outcomes can be made worse during pregnancy and even afterwards. So, you know, in the best of all worlds, I know we're talking about changes in the healthcare system, but what's the one thing that each one of you might think of that, I know you may have a laundry list, but what's the most important thing you think that we need to do to actually focus on improving the health of women and moms, and then leading to the improvement of the healthy baby? So Anushe, can I just ask you to mention what's the one most important thing, and then ask others to chime in as well?
That's such an important question. First of all, Tamika, I'm going to message you later, but thank you so much. I'm so sorry. And thank you so much. And I know your son is so proud of you. I really want to say that, of course, there's a lot of things that we can do, but I really find that in America, it is so hard to talk about racism. And I feel like the pandemic has just exposed us to the world. I mean, we talk about, pre-pandemic, right? It was like, why is there such a big disparity? 3 to 4 times more likely to die Black women. Okay, that number is 243% more likely to die giving birth in America than their white counterparts. What is going on? And for so long, we said such racist stereotypes, right? That Black women are welfare women, or they're not educated. But now we know that a college-educated Black woman is still 5 times more likely to die than her white high school educated counterpart. But if we can't, so we know it's racism and not race. And I think COVID has just established that across the board, not just the healthcare system, by the way, as we know, the justice system. And what really gets to me is then what keeps me up actually is that the system is actually working the way it was intended to work, right? It's supposed to value white lives more. And I don't need to lecture Black women on the history of Dr. Marion Sims, who up until I think last year or the year before had a massive statue in Central Park. But then what about the women that the slave women that he experimented on without their consent? And we know maybe only 3 of their names. So we can't talk about, if we cannot talk about racism, I know that we were joking in the beginning that in our work, I always get, why do you have to make everything about race? But if we can't say it, it's so difficult to talk about racism in America. If we can't talk about that, I don't know where we can go. So I feel like the most important, because what is implicit bias and diversity trainings? What does that mean? I mean, the longer I work in this field, I'm like, no offense for my bluntness, but is that just a nice way for white people to say racism? I mean, what is implicit bias? And how do you measure it or detect it or train it away? You can't. And I know that there's a recent study that came out that's not just Black women, Black nurses. People don't want to be treated by Black nurses and Black doctors. So we have a really big race problem, which I don't want to lecture my esteemed panelists on, but if we can't talk about race, I don't know how we move forward. Honest conversations on race.
You know, Stacey, thank you, Anusha. You talk about the social determinants of health. My question is always, why do the social determinants of health exist? I mean, we need to go way back. But, lots of things are in the works. Anti-bias training, we hear about that every day. Even the Black Women's Health Imperative has an anti-bias training approach for obstetric providers. But I don't think we're going to anti-bias training our way out of this issue. Dr. Kanika Harris is leading our maternal health program, and she's looking at the importance of doula training and having that partner, before you even get pregnant, but during your pregnancy, during labor and delivery, during the postpartum process, somebody who can guide you, support you, ask some questions, but also be a check on your providers to make sure you're getting the care you deserve. But I think ultimately we're going to have some policy solutions. I have this wild idea that if healthcare providers were subject to HEDIS measures based on maternal outcomes by race and ethnicity, somehow, if they thought they weren't going to be reimbursed when Black women and brown women die, somehow they'd figure out a way to listen to those women. Somehow, Tamika, they'd figure out how to do the test that they're supposed to do and listen to you when you say something doesn't seem right. Somehow, I think they'd figure it out if they thought they weren't going to be reimbursed.
I love that you said that, because for me, I have a compliance risk background. And for me, I work at a bank and I know how regulated we are. Like, we have so many regulations, people. It's ridiculous. And I look at healthcare and I look at the fact that this organization or this doctor, they say that they do urine samples. Like, if you go to their website, they do urine samples every single appointment. How is it that I go 8 months without one? Where's the accountability? Where are the controls in place to mitigate risk? What are the controls in place to mitigate implicit bias in healthcare? Like, why can't we design something that checks these balances? Like, there's gotta be checks and balances, and there aren't.
Right, and it wasn't your job to make sure you got a urine test.
Right, like
your prenatal visit. That wasn't your job to ask.
And the onus shouldn't be on women. I mean,
no, it shouldn't. Like, I should not go to your job to tell you what to do.
Yeah, I've become like, I'm an official OB now. But exactly, like, what the heck?
The idea that needing advocates and needing someone, I mean, it's unfortunate, but it's true. I mean, well, first of all, having doulas and midwives, we believe at the March Times, is an essential part of how to reinvent the system of care. And that we are at a point where women, and we know evidence shows that doulas and midwives can improve outcomes for moms and babies. We know that in other highly industrialized countries, we're I think between us and Canada, every other industrialized country has midwifery care fully integrated into maternal care. We don't. So these aren't things that aren't being done in other countries that are new, crazy, newfangled ideas. This is the normal course of how things happen in other countries that somehow we can't figure out how to do here. Dr. Terry, tell us more about what that would mean to really transform the system of care so that we actually have more integrated, have more supports layered in, working with physicians like you.
You took the words out of my mouth. Well, not physicians like me, but you took the words out of my mouth about alternative care models. I mean, like the wish list that's in my mind to improve health outcomes, and I too believe that it's possible, is that we have to think more innovatively. We have to think about community care models. We have to think about medical homes, partnering with leaders in the community, rebuilding our broken trust, and asking the community the best way they would like to receive care. A lot of times I'm in meetings and hospital systems or healthcare systems come up with these great plans, these great frameworks they're gonna roll out, and like nobody in the community is using those systems because we didn't ask them. So I would love to see policies that amplify resources in the community and look different than what we currently have. I also believe it's possible. I'd also like to see us have paid family leave. We're the only, I'm just going to say it again, we're the only industrialized country that does not have paid family leave. And if you're lucky enough to have a good birth experience that's not disrupted, guess what? We still will not give you paid family leave. There are 50 industrialized countries that have paid family leave. I have friends that have actually left the United States, Black women, my colleagues who have left the United States to have their pregnancy somewhere else just because of all the adverse experiences associated before, during, and after. I mean, 3 months, 6 months, a year. I mean, there are industrialized countries where you have a year of family leave for both for both partners. So that's on my wish list as well. We have to think about things that support the family. Healthy babies come from healthy families, and what do healthy families need? We just have to think differently in terms of this. This problem is bigger than what I'm seeing at the bedside.
And one of the
Dr.
reasons,
Terry, I'm so sorry, Miss. I'm so sorry. But to also quickly say that with the US C-section rate, which has increased 500% in the last generation. So also C-section, no paid leave, major surgery, the most common reason people go to the hospital, women go to the hospital, birthing people go to the hospital in America. And then, you know, after 2 C-sections, just somebody told me last year, it's a major surgery. Nobody had ever told me this before. And then we don't even give women, and then you're supposed to bounce back and don't forget to lose the baby weight. I mean, it's just cruel.
yeah, I know we're coming up short on time. And Dr. Terry, the reason I said like you is because, not because you're an OBGYN, but because, you know, we think about doulas as being there for pregnancy and during childbirth. We're postpartum doulas too. They're postpartum doulas that can be with the mom, that can maybe be with her when she's going on wellness checks to her pediatrician, right? We don't have a woman family center, to your point, model of care that is integrated with levels of support. By the way, 1/3 of all moms, 1/3 of all the maternal deaths that happen 1 week after the baby is born out to 1 year.
Yeah.
Presumably she's going to her pediatrician on wellness checks, and she's dealing with, you know, extenuating health circumstances. So anyway, I would love to just reimagine what all this can look like, where OBGYNs and pediatricians and doulas and midwives are all working.
Because it's a solvable issue, guys. It's not cancer or AIDS, right?
Stacey, I'd like to add that it really is boiling down to me, empowering women. They need to, if they do not feel like they are being heard, they need to find someone who will listen. And it's empowering them, finding ways to be able to educate women more about and getting heard.
That's exactly right.
And not just women.
Yes,
right.
They're partners.
Not
The whole family.
Right. The whole family unit.
We all need to know.
We all need to
know.
Yeah.
Especially when your spouse or partner might be the one speaking for you.
Exactly. Absolutely.
That's a very good point.
They are often our most important witnesses.
Absolutely. Yeah. It reminds me of Charles Johnson, who's a good friend of Martha Johnson, how much he advocated for Kira, you know, and so many other spouses and partners.
How scared he was to be viewed as an angry Black man.
Yes.
When they weren't giving the CT scan, he was watching her die. I mean, oh, God bless Charles Johnson.
I'm sure, just like your family advocated for you, I'm sure the same. But it is important. I know we got to go, guys. I'm so sorry.
And
we're going to have chapter 2. How about that? Or
anything. I would love to.
Great. Before we go, I just want to mention a couple of things. One is that we're doing something really exciting at the March of Dimes. Obviously, we've been very involved in federal policy change, but a lot of, I think, Linda, to your point, a lot of these changes are going to happen if we get out and advocate for ourselves. The advocacy we need at the bedside with our doctors, we need that advocacy for us all collectively before these outcomes happen. And there's one way that everyone can get involved, and that's with our March for Change efforts. It's a part of our overall blanket change efforts, taking action in your state. I was just in Georgia for our March for Change event. And I'm not saying this happened just because March Dimes was there. There are a ton of partners in Atlanta and Georgia, throughout the state of Georgia, done a lot of great work. But we had our March for Change event. a couple months ago, and then within a few weeks, Medicaid did get extended from 6 months out to 1 year for all Medicaid moms in Georgia. Our voices make a difference. That's the point, and our advocacy makes a difference. So we want to invite everyone to be a part of the next March for Change event. If you want more information on where there's an event near you, here's the website to go to. And the last thing I just want to say is we have March for Babies going on too. So March for Babies is the big effort to get everyone who has been affected by preterm birth, stillbirth, miscarriage, or if you've had a healthy baby and just want to make sure that every other baby can be healthy as well and every mom can be healthy, this is where you can get involved and help to support our efforts at March Dimes and make sure that this happens. Last thing is just a slide of resources that can reference a lot of what's been raised today, a lot of our panelists and their websites, where you can find their books and where you can find more information about them. All of that is here, and where you can find more information about the effects of racism on maternal and infant health. So again, I just want to say thank you all for joining today. This has been incredible. Look for part 2 to come sometime very soon, but I want to thank all of our panelists for a fantastic conversation, and I look forward to seeing you all again soon. So thanks for joining today.